All right, we got a big unit here with Unit 8, all about clinical psychology. I'm just kind of turning to it as I am starting to talk about it. Note that this is 12 to 16% of the exam will be dedicated to this unit. It's a huge one, so you want to make sure that you don't just get a broad overview from this video. That's what this video is all about. You want to make sure that you dive deeper and are really studying your vocabulary. So let's get started. So again, most of the learning topics and standards are skill 1, concept understanding. But guys, I can't stress to you enough how much you've got to be able to apply these mental disorders to a given scenario. Because in the multiple choice, you're going to see they're going to have a name, they're going to have a case study, and you've got to be able to identify what the person's disorder is. And in the FRQ, you got to dive even deeper. Okay, so really be able to apply this stuff. And then scientific investigation, or skill 3, super important, because there's a lot that they're putting there. The treatment of disorders, right? Treatment of disorders, really all of treatment of disorders. You gotta have that scientific investigation. And like I've said it before, in skill 3, analyze psychological research studies. They're going to give you research studies here about the treatment of disorders, but also evaluating strengths, weaknesses, and empirical support for the different types of treatment for disorders. All right, so in the intro to mental disorders, you want to make sure you remember the DSM, Diagnostic and Statistical Manual of Mental Disorders, and the 5th edition is the most recent one. Making sure you remember the definition of disordered behavior. There's the 4 Ds and the U. Go over those because that's kind of the general guidelines of what makes a behavior disordered and not just slightly off or, quote, abnormal, even though that's really not the right term to use. Making sure that you remember the insanity plea and how that definition is different from what disordered behavior or how disordered behavior is defined, because you're involving the law, right? All right, the approaches are huge here. Making sure that you remember how each of the approaches of psychology, so things like behaviorism and psychoanalysis, right, the psychoanalytic theory, how they explain disordered behavior. So Sigmund Freud was like the guy of this back in the day and was the first one to kind of develop talk therapy, and said that disordered behavior comes from flaws in personality with the unconscious mind, whereas a behaviorist is going to say that it's all learned, right? And that there's strengths and limitations to all of those. Rosenhan's Sane in Insane Places study, where he and a few of his buddies, including Martin Seligman, right, another name of this course, essentially feigned or faked being mentally ill by hearing the word thud and got themselves admitted into psychiatric treatment facilities, and it was all fake. Okay, so making sure we remember that, and how he eventually showed that the assessment and therefore the determined treatment of people who are seen as mentally disordered is flawed, and how it kind of always will be, but that the best shot we've got is something like a DSM. And making sure that we're all looking at the behaviors the same way, and making sure that we're treating people as people and not the mental disorder. All right, a big one here, anxiety, OCD and related, and stress and trauma related. Please note that all 3 of these are different categories, but they're kind of similar, and so I talk about them in one set of notes back in the day, but then also in this in these slides. So anxiety, remembering generalized anxiety disorder, it's anxiety about everything and nothing, and that everything is kind of making you anxious. You could have GAD with panic disorder, where you have panic attacks, but panic attacks could also be separate from GAD. You don't have to have both. And then there's, of course, the specific phobias, which are those irrational, very intensified fears of specific things. You could have all 3 of those, but they are all separate diagnoses. Obsessive compulsive disorder, and remembering what an obsession is, right? It's the intrusive thought that you do not want to think, and yet you keep on thinking it. And then you have a compulsion. Somehow in your brain, you have the illogical link or connection between your obsessive thought and how it's going to be solved with a compulsion. And it's that ugly cycle. If you have the intrusive thought, it causes you anxiety. So you do your compulsion, which causes you a little bit of relief, but that relief goes away. And so you're right back to your intrusive thought or the obsession. And then there's stress and trauma related. The biggest one here being PTSD, post-traumatic stress disorder. Please remember that it's not only soldiers who experience PTSD, but any kind of trauma or stress related disorder that causes all kinds of symptoms, including in some cases even amnesia, but things like flashbacks and things like that. Depressive and bipolar related disorders. Again, these are two separate categories, but we talk about them together because they're similar. So there's clinical depression and making sure you understand the neurotransmitters that are involved here. It's a depressed neurological activity. It's not just, oh, I'm sad. It's not just sadness on inside out. That's not what clinical depression is. It's a depressed neurological activity level in things like serotonin, norepinephrine, dopamine, those neurotransmitters. And the treatment of those oftentimes is the biological or medical treatment with antidepressants, with SSIs or SSRIs. SSIs increasing serotonin levels, but SSRIs being reuptake inhibitors. So they're a little more effective. Then there's seasonal affective disorder, which due to less light in the winter, people feel kind of a depressed or decreased neurological levels. And then dysthymia is now that low grade depression that's longer lasting and not quite as deep or severe as clinical depression. Bipolar, making sure you understand the states of mania and that it's not happiness. No. Although it could be. Mania is like overactivity. It could be excitement, but just the inability to shut your brain off and sometimes not sleeping for days. And then kind of falling off of that and not back to normal, but down into a depressed neurological state of very lacking activity. Dissociative disorders, one category, personality disorders, another. Dissociative identity or dissociative disorders are dissociative disorders, a dissociation or a break in your personality, meaning who you are. That is different from, for instance, psychosis, which we're going to talk about with schizophrenia in a hot second. So a very a small degree of this is dissociative fugue, but it could be really extreme too. So have you ever been on autopilot? That's a type of fugue. A really extreme form of that is when you're on autopilot for like weeks or months at a time and you forget even who you are. Dissociative identity disorder is that multiple personality disorder. And then you have personality disorders. That's different from dissociative. It's personality disorders that some might say it just makes your personality different. It does. It makes your personality, quote, different, but to a point that it disorders and disrupts and is deviant from social norms, right? It disrupts and dysfunctions your daily life. Hence the definition of disordered behavior. There's 3 clusters, and under each of those are lots, but I just kind of give you a few here. Especially cluster B, you want to make sure you know things like borderline and antisocial personality disorder, right? And that there's a lack of empathy, inability to feel emotion and what other people feel, and so there's no guilt, no remorse, and oftentimes they hurt and manipulate other people, but they also are rather charming. They can lure people in and then manipulate and even physically or emotionally harm them. Somatic symptom disorder, think of soma as the body, and that this classification is a mental disorder that manifests itself in the body. It's your brain essentially playing tricks on your body because it is disordered. So conversion disorder is the most known one that you'll want to know about, where it causes severe symptoms like paralysis of your arm or even blindness. There is no physical bodily explanation. It's your brain doing it to you because of some kind of stressful situation or trauma of some sort. Now, hypochondriasis used to be here, but now it's considered an anxiety disorder and is called illness anxiety disorder. So just keep that in mind. There's the neurodevelopment disorders, which are developmental, so things like autism and ADHD. But then there's oppositional defiant disorder and conduct disorder. And making sure that you understand that conduct disorder is essentially antisocial personality disorder in a child. And that no one under the age of 18 can be diagnosed with antisocial personality disorder. Can't do it. That would be conduct disorder. And conduct disorder is really severe, violent or aggressive behaviors that once they're 18 and the symptoms last longer than 6 months, they can be diagnosed with antisocial personality disorder. Schizophrenia, the biggest thing here is understanding it is a spectrum and that your symptoms can be incredibly severe and also not so severe. And it is a psychotic disorder, meaning you have a break in reality, and that a person with schizophrenia or with a psychotic disorder, their reality looks very different than someone else's, than, quote, what is normal. Positive symptoms include things like hallucinations and delusions, making sure you remember the difference between those. Hallucinations are perceptions without sensation, so seeing and hearing things without actually seeing and hearing things. It's in your brain, not in your eyes or your ears. Delusion being false beliefs. I am Mary Poppins, so I can take this umbrella and fly real quick. Not good. And then there's negative symptoms like the flat affect and not being able to essentially feel anything emotionally, and sometimes even physically. Treatment, so huge. Making sure you understand kind of what we talked about at the beginning and how behaviorists would treat disordered behavior, right? And that they're going to treat it with classical and operant conditioning, how a psychoanalyst would treat it. So they're going to do that with talk therapy, and they're going to look for things like transference and resistance, okay? Those sorts of things. Lots of review to do there, so make sure you look into it. Treatments from the biological perspective, again, we don't have time in this video to go over all of them, but this is where you need to know the drugs. So you need to know that clozapine is a treatment for a certain disorder, whereas Zoloft is a treatment for depression, another disorder, right? You've got to know those things like lithium and what they do for the patient, okay? So with schizophrenia, for instance, an antipsychotic med, an antipsychotic drug, think of what's going on in the brain of a schizophrenic patient. Well, it's an oversupply of dopamine. So an antipsychotic drug is going to reduce the amount of dopamine flooding through the neurons. Now, understanding then that causes some side effects like tardive dyskinesia, which is the involuntary motor movements or tics that someone might have. And then there's lots of vocab terms or types of treatment that you want to know, and you'll want to know what perspective or approach they fall under. So rational emotive therapy, cognitive behavior therapy, rational emotive behavior therapy, all falling under the cognitive behavioral therapy realm. And the guys of those are Aaron Beck and Albert Ellis. And essentially they use those theories. Aaron Beck used those predominantly with clinically depressed patients. And Albert Ellis used cognitive behavioral, where they are targeting the thought processes of their patients and pointing out to their patients how flawed and illogical their thinking is. And then if they add the behavioral realm to that, they then use things like counter conditioning, right, to treat the behavior itself and to get that behavior gone. Rational emotive therapy being, rational emotive behavior therapy being the most controversial type of therapy. Psychoanalytic, using things like free association, looking for resistance, avoiding transference. Client-centered therapy with Carl Rogers, all about the client, using active listening and repeating and paraphrasing, that kind of thing, so that they come to the conclusion they need. And then behavioral, using lots of different things like systematic desensitization and flooding and exposure therapy, and operant conditioning techniques like the token economy, all of which to treat the behavior. That was a lot. So again, make sure you're going back, rewinding, pausing, writing down, and then get into some vocabulary and study. We'll see you for our last video coming up next.